This sample shows the appearance of sleep spindles over the left parasagittal region in this double banana array. Here we have anteroposterior left parasagittal, anteroposterior right parasagittal, and then similarly left temporal and right temporal. The phenomenon of interest here is this clearly defined high voltage spike and slow wave discharge with a clear field, repetitive in nature, with some phase reversals that shift, but essentially show it to exist largely over the right hemisphere, both over the frontal and the temporal derivations. If we look at the periodicity of this discharge, we can see that in this case it exceeds 1 second by a small amount, and with minor variations, the periodicity varies between about 1 per second to every 1.25 seconds. As we progress through this EEG sample, we can see that from 10-second segment to 10-second segment, there is minor variability in the inter-discharge interval. This phenomenon is named pseudoperiodic because the discharges are not exactly metronomic, lateralized because they occupy one hemisphere or the other, epileptiform because of the features of spike and slow wave, phase reversals, field, and discharge because it occurs as isolated or rather repeated morphologies. The acronym for this is PLEDS, or PLEDS. Pseudoperiodic lateralized epileptiform discharges are seen in close temporal proximity to clinical seizures. More than 50% of patients with PLEDS will have had a seizure shortly before this recording, or may well have a clinical seizure in the subsequent hours to days. The most frequent clinical correlations of PLEDS appear to be structural abnormalities with intercurrent metabolic or infectious problems. A typical structural cause will be a stroke and less frequently an abscess. Typically, uremia or a urinary tract infection will accompany the stroke, and in the setting of a tonic-clonic seizure, there may subsequently be PLEDS that occupy minutes, hours, or even days afterwards. This EEG segment shows synchronous activity bilaterally. In this array, where you have left from front to back, anteroposterior over right, and we are showing parasagittal derivations overlying temporal derivations, you can see clusters of sharply contoured morphologies. These wax and wane and appear anywhere between approximately 2 per second to frequencies in the region of 8 to 10 per second. It looks a little bit like an accordion going in and out, with concentration of spikes seen synchronously bilaterally here, and here a relative lower frequency appearance of these spikes for about 1 second. In between, however, the spike slow wave morphologies, there is relatively little discernible background activity. Possibly there's some alpha or theta frequency here, but in fact this period of time is significant for relative suppression. As we progress through this recording, you can see that these clusters of spike slow wave morphologies again compress and then appear further apart. Here, for example, is a good example of the suppression of activity and voltage of background between the bursts of epileptiform discharges. These discharges, as noted before, are bilateral. They are predominantly synchronous, and in this case there is some phase reversal once again around the central vertical or vertex region. This sort of pattern is typical of anoxic insult. Since there is a waxing and waning quality to this pattern, and the discharge frequency clearly reaches well above 2 to 4 Hertz at times, this would be interpreted as electrographic status in coma. This is often not to be mixed with non-convulsive status of other causes in which the patient is not in coma and not nearly as obtunded. Returning to this pattern, the periods of suppression between discharges herald, in fact, a very poor outcome and a poor prognosis indicated by this EEG. This EEG was obtained in a child. There are a number of features, nonetheless, outside the brainwave activity which may confuse the interpreter. For example, here we have a sudden upgoing wave with a mirror image on the other side. This is a positive phase reversal. Somewhat before it was the reverse, a negative phase reversal, and we see one towards the end. This phenomenon here represents electrode movement artifact, or even pop artifact of the F7 electrode. What we have here also represents T5 electrode movement, but superimposed on it is muscle artifact, producing this brush-like pattern on both these derivations. Similar artifacts are seen affecting T4. Nonetheless, the feature of principal interest of this segment will be seen shortly. Of note, I've decreased the gain so that the voltage is reflected as 20 microvolts per millimeter. This would be typical of reviewing some pediatric recordings if the voltage is high and there is difficulty in interpreting the waveforms. As we move forward, we can see the artifacts as previously described, but now we encounter a burst of activity. To better understand it and to better see it, once again, we will lower the voltage. Here at 50 microvolts per millimeter, therefore showing that these morphologies are in excess of 200 microvolts, we can see, as we advance the page, that this burst comes out of equal voltage background, largely with some sleep-like activity with spindles, and appears with a phase reversal over F3 and often, in many cases, on the opposite side at F4. Shortly thereafter, though, there is the appearance of spike and then slow wave discharge. In this case, the discharge frequency is at 2.5 per second, or almost 3. In the middle of this burst, it slows down to 2.5 per second. And towards the end of this discharge, it may well slow down to 2 per second. Background activity is seen rather rapidly at the end of this paroxysm. The important aspect is the fact that this represents bilateral synchronous spike wave activity in a patient who shows no myoclonic jerks and shows no tonic-clonic features. This is typical of an abscess seizure and can be seen in many types of genetic epilepsies. It would be typical of childhood and adolescent abscess epilepsy. This EEG segment in a child shows diffuse theta activity with low voltage faster beta activity superimposed. This is obtained from a sleeping child. We already see at the beginning a phase reversal at T4. To clarify this, we can decrease the gain even below the 10 microvolts per millimeter to 15, and we can see a blunted morphology, phase reversing at T4, with an aftergoing slow wave, exhibiting therefore some epileptiform features. As we progress the next 10 seconds, we can see that this is repeated as it continues along in this next segment. You can see over here at the far right the fact that it also displays very good field characteristics. By this we mean that the spike slow wave, although overlapping at this point, has distributed a field of slow wave activity that extends well beyond the actual phase reversal. These sorts of features are essential in determining the epileptiform nature of a discharge. So in summary so far, you look for morphology, and here we have spike or sharp and slow wave. You should have a field, and this we see at the end here, far right of the page. You need to have, if you're in a mid-temporal region, a phase reversal, and this is the component here where we see that the spike component is downgoing in this derivation, F8T4, and upgoing in T4T6. And finally, the fact that this phenomenon repeats over time and isn't just accidentally produced at one point in time. We see further anteriorly, though, a similar synchronous morphology which is occurring at C4. Therefore, this epileptiform discharge is presenting both in the central and the temporal region. Progressing into the next 10-second segment, we can see that this activity previously noted at T4 is now being seen over the contralateral temporal region. And here we see phase reversals that may be slightly further forward at F7, although some of them appear to be at T3. And similarly, as we showed previously, these discharges with phase reversals and morphology, and as a repeated phenomenon, are occurring synchronously at C3. In effect, we have bilateral, independent epileptiform discharges in the central and temporal regions that are going from side to side and are seen during sleep. The stage of sleep is exhibited by the presence of this fast beta activity, which is often a precursor to stage 2 sleep. As we go to the next page, we can see better defined sleep spindles that are occurring in a build-up synchronously, bilaterally, over the anterior head regions, maximally here at F3 and on the other side at F4. During this segment of stage 2 sleep, we see at the far right the epileptiform discharges that we previously described. Some morphological characteristics that help distinguish Rolandic type spikes from others are the very type morphological features in which the slow wave is of relatively short duration but well developed. Furthermore, often the field of Rolandic spikes does not spread significantly beyond the very immediate central and temporal region, as these are found deep in the Rolandic and central fissures and do not extend that much laterally. Over the next several segments, we can see a progression from drowsiness all the way through to slow wave sleep, and during this time, independent temporal spikes are noted with occasional reflection in the frontal region. Here we see a period relatively devoid of epileptiform characteristics. Nonetheless, in the second to last second, there is a spike slow wave at T4. You can see similar features on this page, and as we get towards the end of the recording, we see one of the other typical characteristics of centrotemporal spikes or Rolandic spikes, and that is the profusion of appearance of these spikes during periods of sleep. Here you can clearly see that they can appear on one side or the other, and in fact one would be able to easily place 3 of these morphologies in a 1-second period. In sum, we have seen several features of epileptiform activity. We have seen flurries of sharp slow waves and spike slow waves with a frequency that increased to 3 or even 4 per second, occurring independently over each temporal region, but also being reflected in the central or frontal head regions. These spikes are seen independently increasing during stage 2 sleep, as we notice sleep spindles and slow activity of this stage of sleep. This phenomenon of Rolandic spikes is seen in Rolandic epilepsy. This is otherwise known as benign epilepsy of childhood with centrotemporal spikes, with the acronym BECTS. This EEG also shows a bipolar montage. In this case, this is an adolescent who is awake. Next to the black arrow, you can see the posterior basic waking rhythm. In counting it out, it is at about 11 Hertz. This alpha rhythm is within normal range. We can begin to see some morphologies here that are spike-like. In fact, they've occurred a little bit earlier and are of relatively low voltage and are seen over the frontal head regions. Towards the end of this 10-second segment, we see similar morphologies. We can also see here a brief run of about 3 such spikes. They are slightly asynchronous, but are nonetheless present bilaterally. If we look at the next 10-second segment, we can see a better developed spike and slow wave, in this case over the right frontal region, phase reversing at F4, but we can also see one on the contralateral side synchronously at F3. The patient is awake, as we saw before with the posterior alpha rhythm, and here we can see that there is an eye blink, further showing the wakefulness of the patient. As we go through these segments here, we can now see bursts of polyspikes, again over the frontal head regions, and again during wakefulness. In the final portion then of this segment, as I back it up by a few seconds, you can see this burst initially starting in the frontal head regions and then rapidly generalizing here on the right and here on the left with an interdischarge frequency of about 4 Hertz, and as noted before, heralded by polyspikes seen at the beginning but also between the spike slow waves. In this case, there are 2 spikes, one here and one here. These bursts of polyspike and spike slow wave at 4 to 4.5 Hertz in an adolescent would be typical of a genetic epilepsy and is often associated with juvenile myoclonic epilepsy.